It's great to be here with everyone, and I've set a timer on to help me keep track of time and make sure I don't go over and leave time for questions. One thing I'd like to just note, yesterday I got some good news. I got a fundable score on a new project examining bullying and victimization in US schools. And so I'm not talking about that now, but if you're interested, I've got some slides at the end and I could talk more about some new research we'll be conducting in that around that
Great,
important topic.
yeah.
Yes, thank you. So
Congrats.
I can set, thank you. I can set time aside for that to talk as well. So let me get to screen share. Thank you. And click on this and new slideshow. And can everyone see those slides? And I'll turn off closed captioning.
I think
Good to go? Okay, great.
Yeah.
All right. Just a few acknowledgements. This is work that's collaborative, including with George Farkas, University of California, Irvine, who's a sociologist, and Marianne Hillemeyer, who recently retired from Penn State, who's a health policy researcher. And we've been fortunate to receive funding from a variety of agencies, the Department of Education's Institute of Education Sciences, NICHD. These are indirectly supported through an infrastructure grant at Penn State. The Spencer Foundation has funded this work. But of course, I don't speak for those agencies. I'm just reporting findings that have been supported generously through those agencies. I think it's good to start with a reminder that injustice in healthcare, as put by Dr. King, is such an important issue and has the potential for so many negative spillovers in terms of children's development across time, the population I'll be focusing on today. And so what I'll be talking about is the topic of who seems to be identified as having disabilities, whether in pediatric clinics or in US schools, with a particular focus on examining racial and ethnic disparities in disability identification. I'll overview the findings after providing some context, and then I'll conclude with a discussion about the implications of the work for health equity policy research practice. Others have examined racial and ethnic disparities in children's health and healthcare and concluded that these disparities are extensive, pervasive, and persistent. But there are limitations in the available knowledge base, which I can go into some more detail. Many of the studies that have examined health disparities, including in regards to disability identification, have tended to be cross-sectional and been unable to account for potential confounds that are important to consider if we want to know whether there's potential bias operating in the way that children are being provided with healthcare, including through disability identification. There is some reporting on these differences, I'll call them at this point. Most of the work and investigation of this topic, kind of on the education side, has concluded that schools may be biased in terms of over-identifying children of color as having disabilities. And you can find some evidence of this just descriptively in data collected by the US Department of Education. So here, if you attend, I've tried to highlight kind of key demographic groups here: American Indian or Alaskan Native children, Black or African American children, or Hispanic Latino children. And if you attend to the numbers on the far right column, numbers greater than 1 are suggestive that that particular group, say Black or African American children, have been receiving services for disabilities more relative to other population groups. And this has led to some concerns that maybe the way that children are being identified as having disabilities might be biased, such that schools, for example, are over-identifying children of color as having disabilities. And there has been some federal legislation and regulation about this that requires states and localities to monitor for the extent that children are being identified as having disabilities, with attending, I would call them incentives, mechanisms that are designed when such disparities are being observed to artificially reduce the likelihood that children of color are being identified as having disabilities, which I can talk more about. Much of this work is descriptive And it's important for them to investigate whether there's potential bias operating in the way that children are being identified as having disabilities, to keep some key considerations in mind. So this is a figure from a report by the Institute of Medicine in 2004. And what the figure is trying to highlight here is, I think, an important idea to keep in mind. So if we look at two different populations here, non-minority and minority populations, we might observe differences in healthcare quality that's being provided to those two different populations. And that could constitute a difference. But there are different explanations for that difference. And one explanation might be the appropriateness, the clinical appropriateness, or the patient preferences for the type of healthcare that's being provided. And that's a reasonable potential explanation for the differences being observed. But accounting for clinical appropriateness and potential patient preferences, we might observe a difference that might have other explanations. Here, the operation of the healthcare system, potential bias, or stereotypical type perspectives or discrimination that providers might be displaying. And those are unreasonable explanations for the difference. And those kind of more unreasonable explanations constitute evidence of potential disparities that aren't explained by differences in clinical appropriateness. So if we want to know whether there's potential evidence that any observed differences are a result of bias and therefore constitute a disparity, the standard way to do this in the social sciences is to compare children who are similarly situated. And so that they might display similar levels of clinical need, similar and material aspects related to a diagnosis that might be made. And then after making those kinds of contrasts, if we have evidence of differential treatment, we have stronger evidence that potential bias may be operating. This is the standard that is adopted. This is one of the standards. The other standard is disparate impact, which I can talk about. But I think the primary standard we should be concerned with, for reasons I can provide today, is evidence of differential treatment. This is the standard that's used by the National Research Council. The US Department's Office of Civil Rights has also used this standard, as well as many different legal precedents. This is a type of standard that's conducted in scientific investigations. So in public health, among similarly situated children brought into emergency rooms with elevated temperatures, who's more or less likely to receive follow-up testing and care? Or in economics, among similarly situated applicants for employment, who's more or less likely to receive callbacks? Or in education, for gifted education services, among similarly situated high achieving children, who's more or less likely to receive gifted education services? And so we've been trying to approximate these kinds of contrasts in examining racial and ethnic disparities in disability identification. So our analytical logic is attempting to hold other explanatory factors, account for those other explanatory factors, and by doing so, evaluate evidence for potential bias in the way children are being identified as having disabilities and provided services. And so kind of from an epi standpoint, this, you might illustrate this is concerned with potential confounding. So I'm interested in this XY relationship. Are children of color more likely to be diagnosed with some conditions, say asthma? Or if I'm concerned about disparities in discipline or suspension, boys relative to girls, who's more likely to be suspended? So I'm interested in gender / biological sex and its relation with school-based discipline, or racial and ethnic background and its relation with asthma diagnosis. But there's a potential other explanatory factors that might confound those relations, and I need to be sensitive to those, because if I don't take those into account, my estimate of this relationship between the XY variable could be spurious. So what we're trying to do is account for other potential explanatory factors, and for historical and ongoing racialized practices and racist policies, relative exposure to factors that relate to disability are unequally experienced in our society. So if we look at, as an example, exposure to poverty, about 30% of Black and American Indian children relative to 10% of white and Asian children are experiencing a poverty in the household. Why is that something to note? Because exposure to poverty itself increases the likelihood of exposure to the risk factors for disability. So if you're experiencing poverty, you're more likely to be born with low birth weight, you're more likely to be exposed to lead, you're more likely to be exposed to air pollution or various environmental toxins. And these factors themselves relate to the likelihood of having a disability. Other work finds that not only is poverty more likely to be experienced at the family level by children of color, but also by the neighborhood level. So children who are American Indian or Black or Hispanic are more likely to live in neighborhoods where 30% or more of the households are also experiencing poverty. So in addition to any risk factors exposed to in the home, this greater poverty exposure is also taking place in the local context, the neighborhood. In terms of functioning in school, there's a great deal of research that's documented disparities in achievement. So that if you look at recent assessments that are given nationally, assessing children's reading or math achievement, you can find evidence of large differences in academic performance by race, ethnicity. So for example, using a standard used by the Department of Education of below basic, and so not even partial mastery of grade level material, about 23% of children who are white are displaying below basic levels of reading achievement, in contrast to about 50% of children who are Black, Hispanic, or American Indian. Why is this? This is important for many reasons. One reason it's important is achievement itself is a key variable for disability identification. It's a symptom of whether you potentially have a disability. So what we're trying to do in our analyses is to compare children who seem similarly situated, who are observationally similar, including in factors materially relevant to having a disability. And we do so by analyzing nationally representative and multi-year longitudinal data sets, as well as very large cross-sectional data sets. We control for potential confounds, including well-designed and direct measures of children's academic achievement, as well as, depending on the data available to us, behavioral functioning. We oftentimes have extensive data that's been collected on the children's and families' medical histories. We also have good measures of the family socioeconomic status, the school level resources, as well as regional variation. So observationally, and that's an important limitation of this work, observationally, we can approximate contrast between children who seem similarly situated, including in their likelihood of having a disability, so as to investigate for potential bias in how children are being identified as having disabilities. So what do we find? Across many analyses, we find consistent evidence of under-identification, such that relative to white and English-speaking children, children who are Black, Hispanic, Asian, American Indian, Pacific Islander, of other race ethnicity, or are from non-English speaking households are less likely to be identified as having disabilities. We observe that for disabilities generally, and we also observe it across many specific disability conditions. We observe it prior to when children arrive in school, and we also observe it in elementary, middle, and high school. We observe it using parent report, teacher report, or school record of children's disability status. And in this point, we've observed it across analyses of about 40 nationally representative samples. So let me highlight some of those findings. So we've conducted 2 investigations looking at racial and ethnic disparities in ADHD diagnosis, one which we published in Pediatrics, the other in Journal of Child Psychology and Psychiatry. And this provides an example finding from the work. So this is showing you the probability of being diagnosed with ADHD across time. Here in a sample of children followed from kindergarten to the end of middle school. And you see 2 types of results here. One is which the likelihood increases over time up until about 3rd grade of being diagnosed as having ADHD, and then the likelihood starts to decline. The other result is there are differences across the racial and ethnic groups in the likelihood of identification. And importantly, these are in analyses that have controlled for a range of potential confounds, that whether the child were born with low birth weight, the family SES, the child's health insurance coverage, the English language use in the home, and time varying measures of externalizing and self-regulatory behaviors, as well as academic achievement. So these children are similarly situated in terms of their likelihood of ADHD, but yet we're finding evidence of disparities across racial and ethnic groups. This figure highlights this finding in a slightly different way. So here, if you look at the end of 8th grade data, we're observing that about 7% of children who are white have been diagnosed as having ADHD in these analyses, relative to, say, 3% of children who are Black. Again, in analyses accounting for potential confounds. We've also observed this for other specific conditions here, in whether children have been identified and so receiving services for speech language impairments prior to school entry or by school entry. And if we look at these analyses, we find, in essence, some findings that make sense and some not so much. So the findings that make sense, I've tried to highlight a little bit here in green. So if children are displaying a very low level of language acquisition by 24 or 48 months of age, they're much more likely to be receiving services for speech language impairments. And that's highlighted in the top green here. So an adjusted odds ratio of 9.12 for children displaying low levels of vocabulary by 24 months of age, in the likelihood of receipt of speech language services at 48 months of age. And we also see that net of that, displaying a low level of vocabulary knowledge at 48 months is also associated with a greater likelihood of receiving services for speech language impairments. Other factors also make sense. So whether children were born with very low birth weight or moderately low birth weight, or whether there's a history of special needs or disability in the family, or whether children were displaying difficulties in behavioral functioning earlier, these are predictors in receipt of services by 48 months of age. But conditional on those other explanatory factors, we're finding other findings that don't make as much sense. So we're finding that children who are Black and who are from non-English speaking households are less likely, conditional on these analyses, of receiving services for speech language impairments. So despite the analyses correcting or adjusting for many explanatory factors, and so resulting in contrast between observationally similar children, again, children who are white or English speaking are more likely to be receiving services for speech language impairments. And not shown in for this particular study here, but this finding also replicates at 24 months of age as well as 60 months of age. We've extended these analyses. So here in this particular study, we examined across a collection of disability conditions: learning disabilities, speech language impairments, intellectual disabilities, health impairments, and behavioral or emotional disorders, in a nationally representative longitudinal study. And what we find, again, is the factors that you would expect seem to be related to the likelihood of being identified as having a disability. So as children's academic achievement increases, the likelihood of being identified as having a disability decreases. As children display better attention-related behaviors in classrooms, again, their likelihood of being identified as having disabilities decreases. Children who are displaying more acting out disruptive type behaviors are more likely to be identified as having behavioral difficulties or disorders or emotional disorders as well. Again, these are analyses correcting for other potential explanatory factors. Conditional on those analyses, we find that children who are Black, Hispanic, of other race, ethnicity, are coming from non-English speaking households are less likely to be identified as having disabilities. So for example, in analyses adjusting for these and additional explanatory factors, children who are Black are less likely to be identified as having learning disabilities, speech language impairments, intellectual disabilities, other health impairments, or emotional or behavior disorders. Let's see here. Just displaying this figure in a figuratively, you see the same kind of type of result that we observed earlier. So here in these survival analyses, over time, more children are being identified as having disabilities, but despite adjustment for potential explanatory factors, we're observing that white children are consistently more likely to be identified as having disabilities than children of other race, ethnicity. An intuitive way to understand this finding is displayed here. So if we look at children who are entering in US kindergarten classrooms, who are displaying difficulties academically. So these children are all entered kindergarten classrooms displaying levels of academic achievement in the lowest 10% of the total score distribution, whether it's assessed in mathematics, reading, or general knowledge. Among children displaying clinically significant, arguably, difficulties academically, children who are white are consistently more likely to be receiving services as a result of being identified as having disabilities than children who are Black or Hispanic. So among children who entered kindergarten displaying clinically significant levels of reading difficulties, say at the start of kindergarten, as illustrated in this part of the figure, about 40% of children who are white are receiving services for disabilities in third grade. The contrasting percentages for children who are Black or Hispanic are about half that. We've subsequently replicated this finding in cross-sectional data of samples that are quite a bit larger, of upward to 200,000 children attending US elementary, middle, and high schools. We again find that relative to children displaying low levels of academic achievement, among children displaying low levels of academic achievement, that children who are Black, Hispanic, or American Indian are less likely to receiving services, supports for disabilities than children who are white. And that's shown here in this figure. So if I could just walk you through that for a moment. So a way to look at this graph. So we've taken the academic distribution here in reading. We also replicate this in other academic content areas, including mathematics as well as science. Here, if I take this particular column here for children who are white, and then take the distribution and slice it by deciles, this is showing me that among children who are white, of those who were whose reading achievement was in the lowest 10% of the total score distribution, in fourth grade, almost 75% of those children have been identified as having disabilities and are receiving additional services and supports. As children's academic achievement, here is illustrated in this column, increases, the percentage of children receiving services for disabilities steadily decreases, which makes sense. So relative to 74% of children who are white in the lowest 10% of the total reading distribution receiving services, only 2% of children who are white in the top 10% of the reading achievement distribution are receiving services. And if you look across the rows, we have another type of finding, which is relative to children all displaying similar levels of reading achievement, children who are white are more likely to be receiving services for disabilities than children of other race and ethnicity. So relative to 75% of children who are white who are displaying clinically significant reading difficulties, the percentage of children who are Black, Hispanic, American Indian who are receiving services are 44, 48%, with similarly lower levels, lower percentages observed for other racial and ethnic groups. And that finding continues across other deciles of the distribution. In more formal analyses, we've adjusted here for different disability conditions as well as disability generally. When adjustments are made for reading achievement, gender, exposure to economic disadvantage, whether children are English language learners and receiving services as a result of being English language learners, or a school fixed effects control for school level resources. And so comparing children attending the same schools, we find consistently that children who are Black, Hispanic, as well as other racial and ethnic backgrounds are less likely to be identified as having autism, other health impairments, learning disabilities, speech language impairments, other conditions. With the magnitude of the disparity is quite large. So a percentage difference in relative odds of identification of around 50 to 70%. If we look at this across time, and so comparing children displaying similar levels of academic achievement, we again find that children who are white are more likely to be identified as having disabilities than children of other racial and ethnic background. I've recently used a new type of sensitivity analysis developed in epidemiology, e-values, some of you may be familiar with them, to estimate whether unmeasured confounding may explain these observed disparities, and the estimates from those calculations suggest that unmeasured confounding is an unlikely explanation to explain the observed disparity. So unmeasured confounding is unlikely to result in a change of direction of the estimate of the disparities or result in null findings. And then last, and I'll get on to implications for the work, in new analyses that were just accepted for publication in Journal of Learning Disabilities, we try to extend these analyses in a different way, so a little different than what I've been talking about so far. So what in this particular study, what we've done is we've looked at children who seem unlikely to have disabilities, in this case specifically ADHD, because there's been concern about potential overdiagnosis of ADHD. And we've wondered whether among children who seem unlikely to have the condition, whether we would also observe racial and ethnic disparities in either diagnosis or treatment as indicated by receipt of medication. And across the analyses we've conducted, when we compare children who are displaying, who are high functioning, so just not displaying problem behaviors, who are displaying high levels of academic achievement or high levels of executive functioning. In those analyses, we're observing that children who are white are more likely to be diagnosed or receiving medication for ADHD. So what are the implications for this work? It suggests to us that evidence of systemic bias in the way that children are being identified as having disabilities in the United States across both pediatric clinics as well as in schools. This lack of access to treatments, services, and supports for disability has been hypothesized to help explain achievement gaps in the United States. Others have hypothesized that this underdiagnosis may be resulting in children being more likely to experience what's the metaphorical school to prison pipeline, such that children who are white may be more likely to have their difficulties medicalized through services, supports, treatments, medication, whereas children who are not white might be more likely to have their difficulties criminalized, and so experience expulsion, suspension, and so be more likely to experience engagement with the criminal justice system as a result. The findings suggest to us that federal policy and legislation should be more carefully monitoring for the problem of under-identification. This is why our result, I think, is being cited by the CDC or the US Commission on Civil Rights or the American Academy of Pediatrics, because we're suggesting a problem that hasn't really been recognized well to date. In terms of additional health equity implications, I think it suggests the need, as has been suggested to address other types of disparities in pediatric care or in education, that the system tends to operate on the basis of either parental or teacher referral or some solicitation of a developmental concerns by a pediatrician. And what we're suggesting is that may be introducing bias in the way that children are being identified as having disabilities. And so one way to potentially ameliorate that bias is to instead adopt universal screening procedures. So this has been suggested as a way to better identify children who have dyslexia, as well as to address previously reported racial and ethnic disparities in receipt of gifted education services. Another potential mechanism to address these disparities is expanding clinic and school to community partnerships, where a member of the community is is brought into the clinic or the school, receives training on the signs, symptoms of or available treatments for disabilities, and then helps disseminate evidence-based information in the community. And that's been suggested as a way to address these disparities, as well as some discussion that greater access to evidence-based information, say through brochures that might be disseminated about, say, the signs of autism, may also be helpful for addressing these types of disparities. It suggests to us that greater attention to the needs of children of color and who are from non-English speaking households should be made, should be implemented. Other work has suggested that pediatricians and providers are more likely to solicit developmental concerns from white families. They're more likely to spend greater amounts of time with white families. We're observing that in other analyses that I could discuss. And it also suggests to us that in examining the issue of racial and ethnic disparities, we should be sensitive to making sure that we're taking into account clinical appropriateness and need, so as to better assess for potential bias and discriminatory practices. And with that, I'll stop and happy to answer other questions. And I've stopped at 2:40 like requested. So I've left plenty of time
for
questions. So
there you go. Thank you. I think
you're welcome. Thank you.
I wanted to put my applause sign up if I, or maybe my
hey.
There you go.
Thank
celebration. You. I think people that can applaud but also thank you so much for the clarity, Paul. And I had a couple of questions, but I'm going to open it up also to others.
Okay.
So please take yourself off mute and jump in. I see Nir's hand up. I'm looking through. Go ahead, Nir.
Thank you. Wonderful talk. Incredibly teacherly and lucid.
Maybe introduce yourself real quick. I know you have before.
Sorry, my name is Nir Eyal. Nice to meet you.
Nice to meet you.
Direct something called the Center for Population Level Bioethics. So very much interested in, what would count as equitable, what would not count as equitable. Apologies in advance for my layman understanding of epidemiology. So,
no
so you'll see both, all of that maybe.
Okay.
So I thought of a way that one could be more critical of the U.S. system and a way that one could try to defend it. And I'm going to run both by you and see.
Sure.
Would love to hear what you think. So the way that one could be more critical is you started out by conceding, look, if it's a matter of different preferences, then there's no disparity here. One could say, well, it depends. I mean, the different behavior, at least preferences as they are expressed in people's behaviors, the behaviors might be because people anticipate maybe correctly that they will, if they try to get the benefit, they will not get it. That the benefit for them, there's a lot of literature and, from the UK and why the working class don't even apply to Oxbridge. Well, if they got in, it would be hell, right? Because you see where it's heading, right?
Yes,
Women don't want to go to that doctor because you know how that doctor treats, so et cetera, et cetera, et cetera. And so presumably part of that is happening even when there are differences in preferences, and maybe you don't need to, of course, some differences in preferences we do need to respect, but maybe not all of them should get the U.S.
Right.
So I don't know, that's one suggestion. That kind of the defensive suggestion might look as follows. One could try to argue what is happening in the school is that the teachers we could also talk about rich and poor, not white and black, as you did. Assume that economic differences and other SCS differences are part of what is driving the phenomena you described. So, the people coming from, we have a school with a mixed population, say, the kids coming from the rich households, we know that they've had every private tutor possible. They've had a lot of attention. If they can't read, there seems to be something biological going on, and we want kind of medication to address this. With the other kids, I don't know. chances are it's something environmental. So they neglect at least the medication part.
Mhm.
And then later on it hits that, this kid is creating problems. So maybe my heart goes out to that kid, but
Mhm.
there's nothing I can do. I can't change their environment
Right.
very profoundly.
Right.
Okay, send them to pipeline to jail. You see where this is leading.
Right. Yeah.
It
Those are
doesn't
good questions.
come out of racism. It's a terrible outcome. It's maybe a structurally racist outcome, and very bad. We should address it somehow, but maybe not the unabashed kind of discrimination that might first appear when one
Right.
looks at your amazing findings.
Right. Yeah. These are good questions, and I certainly appreciate. It could be this. It could be that. What do you think about this, or what do you think about that? I love those kind of discussions. I think they're very productive. I'd say a couple things in response. If the parent doesn't want their child to be identified as having a disability, of course the parent has a lot of say about that. So especially in school-based context, there's a lot of protections that are built in to the disability eligibility process, such that parents who do not want to have their child identified as having a disability have enormous say. And of course that's important. And as you say, patient preferences, I think are very important. In my sense of things is that we're not at the point yet where these disparities are just the result of differences in patient preferences, because there's a lot of reporting that families across racial and ethnic backgrounds are experiencing great difficulty in having their children evaluated and appropriately diagnosed. The way that the way you would initiate a disability eligibility process in the schools, if the schools doesn't want to do it, you have to go out and pay someone, some professional, some psychiatrist, neuropsychologist to conduct the evaluation. And even then the school can decide, well, we're going to do our own, or we don't believe those findings. And in fact, there's some qualitative work finding that among Black middle-class families, they're experiencing great difficulty in having their children receive services, even after they've received a formal evaluation by an outside provider that the child has a disability. So I think there's a lot of work that we can do to make sure that the system that we're making sure that the way that we're providing care and services is resulting. So any observed differences because of patient preferences, I don't think we're there yet. And from my standpoint, and the other point I'd make is I kind of want two conditions in myself, from my perspective. I don't want children who don't have disabilities to be diagnosed as having disabilities. And I don't want children who do have disabilities not to be diagnosed as having disabilities based on race, ethnicity across both conditions. From my experience as a social scientist, there's lots of reasons to believe that children who do have disabilities, if provided with treatments, services, their outcomes tend to be better than those who are not provided those treatments or services. So I don't think we're there. From my perspective, I don't think we're there yet in terms of having a system that's fully responsive across all families and all children in how we're allocating services and supports for disability.
So, Manny, can you jump in and introduce yourself too?
Sure. Dr. Morgan, thanks so much for a fantastic talk.
Thank you, sir.
Really terrific. So I'm Manny Jimenez. I'm a developmental pediatrician and child health researcher at Rutgers in the departments of pediatrics and family medicine and community health, and also part of the Bog Center on Developmental Disabilities. I guess one question as I came up as I was listening. To what, how do you think about sort of availability of resources here as well? So, even just comparing districts like in New Jersey, where you have some districts where, upwards of 80% of the kids have, limited reading proficiency in third grade, compared to to other districts, which have, far fewer kids. So I guess if you could just kind of sort of help me kind of think through that.
Sure, that's a great question. I haven't talked about it here. We have observed evidence of something we've referred to as a frog pond effect. So what do I mean by that? If you look, the simple way to put it, I guess, would be the context that you find yourself in the school seems to be related to your likelihood of being identified, such that let's say the average achievement score for children with disabilities, let's say it's 50. Well, if I'm in a school where the average achievement score is 150, I'm going to stand out a lot more than when I'm in a school where the average achievement score is 75, right? And so you have to be especially bad. Your achievement has to be especially bad if you're attending a lower performing school to be noticed by teachers, would be another way to put it. And so we do find some evidence of that. And we also and others have observed some evidence of school-based contextual factors that I can talk about more. From a screening standpoint, and this kind of relates back to Nir's good question too. You have a lot of disadvantage, right? That's more likely to be experienced by children of color in terms of the quality of the schools they provide, but also other sources of care. So lower access to pediatric clinics or dental clinics, experiencing more barriers because of a lack of health insurance coverage. Or even if they have health insurance coverage, providers not taking that coverage, not taking Medicare or not taking insurance at all. And then the services are quite costly for families to secure. So what does this all mean? I think there's a lot of work to do is I guess what I would say. There's a lot of work we have to do to make our health systems more equitable. And I'm finding repeatedly evidence to suggest that another source of inequity is that families who are better situated are more advantaged by the basis of their skin color or the language they speak or their economic background are securing treatment, support services for their children in relative to families who differ by those characteristics. And that to me is a tragedy and an inequity that we need to attempt to ameliorate by training providers to be more culturally sensitive, to be aware of this problem. And if we could at least get to the point where we felt like families are informed, or whether it's through schools or through pediatric clinics, I don't think we're at that point at all yet in terms of the way we provide services. And that's disadvantaging already historically disadvantaged populations further, in my opinion.
Hi, I'm Angela.
Yeah, Angela. Yeah.
Can you hear me?
I can. Please tell us.
My 1 second.
Either way was good.
Yeah, it's just sometimes I can't hear with the earphones on, and I'm not sure if you can hear me. But I guess my question was, it's in the last couple of years. By the way, I'm Angela from the Office of Global Health at Rutgers, Robert Wood Johnson Medical School. My question in regards to the current defunding, as you would call it, of a lot of school districts across the country, where some states have 4-day school, 3-day school, whatever you would call it. How does then this new information, with which I think the research supports what most people think, just now the numbers are there to show it. How does then this research fall into the now new, if you would call it that,
Sure.
school system that's happening across America,
Right.
and further disadvantaging students?
Yeah, it's a great question. Thank you, Angela. I would imagine it's going to make things worse and exacerbate an already bad situation. So, maybe if I can extend that a little bit and think about within sort of the COVID context, with many families experiencing just remote-based instruction or less involvement with teachers, what I think is like, I don't have data to show this, but I'm going to conjecture that the type of problem I've been reporting has only gotten worse, such that advantaged families have sought additional support for their children academically, but also have been attending schools where they're more likely to be interacting with teachers or social workers or counselors, versus other populations where they've been mostly based, their instruction has been mostly be remote, and families are unable to be around the children as much throughout the day because of their work schedules and these kinds of things. So I suspect that some of the things that you've referenced in terms of less access to school is only going to exacerbate the type of disparities we're observing here.
Mm-hmm. Yeah. I'm wondering if there's a policy recommendation on a federal level that, which I don't know how well it plays into it, just because the funding for education has been getting cut on year. But how, I guess, in the new landscape and the new issues that COVID brought up, where the federal government, from this research and probably others going across the country, can be incentivized to actually fund early education, and especially when talking about the screenings and how exactly that would play out and how that would look like.
Right. That's a great question as well. We observe these disparities repeatedly prior to school entry. So in addition to what I presented today, we also observe this across other health conditions besides speech language impairments. Others have observed these types of disparities by 24 months of age, as well as 48 and 60 months of age and other time points, but prior to school entry. And I've been hopeful that we would expand as a society greater access to universal pre-K, because I think it stands to be of benefit to children in many ways, as well as families. One way that one way from my kind of neck of the woods, so to speak, that might be a benefit is, what you have is a real hodgepodge of service delivery prior to school entry. Once children enter school, there's variation in school-based resources and access, but the system is supposed to operate the same way, generally, in the way disability is identified and then treated in schools. But prior to school entry, that doesn't happen at all. So kids either they're going to preschool, or they're at home, or they're in center-based care, or they're in family-based care. And they're going repeatedly, regularly to well child visits, or they're not. And it's, the families either have health insurance coverage or they don't. And these are all influencing the likelihood of being identified if you have a disability, which is operating in ways that are especially disadvantaging families of color who are not English speaking, who are experiencing economic disadvantage. So a greater access to, I think, a universal setting might help ameliorate some of these and help children who do have disabilities be appropriately diagnosed and receive care earlier. There's other work, which I haven't talked about today, which is documenting evidence of disparities in autism diagnosis between children who are white and Black, with children who are Black who are displaying similar levels of symptomatology for autism, on average receiving diagnoses a year or two later than children who are white. And from a intervention standpoint, that's not a good thing, because a year or two later, can make an enormous difference in terms of the child's development across time. If we can provide services earlier, they're much more likely to be effective than if we're providing them late. So anyway, I don't know if that answers the question satisfactorily, but those would be some thoughts I would have.
Right. No, the idea of the standard K, I know the vice president that was one of her initiatives.
Absolutely.
Okay, but hasn't gone off yet. So
okay, right. Unfortunately, yes, from my perspective. So.
Yeah.
So Deborah, maybe you can wrap it up with our last one. Deborah, take yourself off mute and introduce yourself.
Thank you. And thank you for a wonderful talk.
No, thank you.
I'm a professor in pediatrics and family medicine and direct the Boggs Center on Developmental Disabilities. So very intrigued, impressed with you. And I have many thoughts about it, but I wanted to go back to your balancing between not wanting children overdiagnosed and not wanting children underdiagnosed. And to your last point about the later diagnosis, you then lose out on different entitlements, which is a huge issue. And also the variation across states of how those entitlements are realized. But one of the things that feels somewhat ironic and contradictory to me is that the whole issue of parental advocacy and that somewhat of the organized parental advocacy, both on one hand for individual children, but sort of organized movements around disproportionality is addressed at over-identification.
That's right.
And there isn't the same energy or constituency for under-identification.
Right.
Because it's somewhat, you don't know what you don't know, or you don't know what you have.
That's right.
So there's a community organization, parent education, advocacy, sort of social contract issue.
Right.
This. So
I think it's wonderful. And I would love to have further conversations with you too. It sounds like we have a lot of overlapping interests. You raise great points. In regards to the concern about over-identification, I think that's true. That's been present for quite a long time. And of course, there's a legitimate concern, but what's the evidence for it? And if you look at the available evidence for that, much of that work is based simply on descriptive statistics. There's no attempt to adjust for differential exposure to poverty or differences in clinical need. So they're apples to oranges contrasts. They're not apples to apples contrasts. Once you do the apples to apples contrasts, whether in our work or others' work, you consistently find evidence of under-identification. Now, in regards to advocacy, I think that's changing. And I've been sort of in the weeds in this topic for a bit of time, and I can see a much greater attention to under-identification within minority populations. So there's been several reports of this, say in the Washington Post or by Kaiser Health News. Mashable have been highlighting the lack of diagnosis that high functioning women of color had experienced for ADHD. And once they received a diagnosis and were provided with care, what a huge difference that was making in their life. And also they had experienced misdiagnosis where they were being diagnosed with anxiety or depression, when instead it was an attentional difficulty they were experiencing. So I think and I'm seeing this also with dyslexia. I've been talking and gave talks recently to the Dyslexia Foundation. There are new advocacy groups of families of color who are now realizing that their children have had dyslexia and not been appropriately diagnosed and have not been receiving care. So I think that over time, there'll be greater attention to the potential of underdiagnosis, and there'll be more advocacy as a result. And again, if a child doesn't have a disability, or if the family doesn't want their child diagnosed, I completely understand, about that. A child shouldn't be diagnosed if they don't have a diagnosis. But I think the preponderance of evidence, at least from my standpoint, suggests that the way that the services are being provided for disability across the health and educational system is really advantaging the populations that we've observed are usually advantaged, which are white English speaking, better economically resourced families.
Dr. Morgan, if I
Yeah.
may jump in, because I see here in the chat that Dr. Sunanda Gaur, she's a professor of pediatrics at Robert Johnson Medical School. She's no longer on the talk. She had to
Okay.
jump off, but she put a comment here saying she wonders if white parents are more proactive in bringing learning issues to the
Yes.
attention to schools.
Yes,
and
I think
doctors.
that's absolutely right. And it's a great observation. I think that's right. There's some more work that has to be done in this area from my standpoint, but there's some suggestive evidence that white, better educated families are more likely to view their child's difficulties as having a neurobiological explanation rather than an explanation of potential bias by, say, teachers, for example. There is some very understandable concerns in minority communities about potential stigma. Families of children who do have disabilities, who are, say, Hispanic or Black, report that they experience and their children experience stigma in the communities. So there is a concern about that. It suggests to me that the potential for disability has been unrecognized. That families of means are using the system. The last set of slides I showed about ADHD among children who don't seem to look like they have ADHD, and finding that white children are more likely to be diagnosed and using medication is suggestive of this explanation as well.
Yeah, I think a couple of these examples is going to bring up my point, but we have to wrap up with people have dropped off because after the hour, but the discussion was so rich. I want to keep it going. We do have this recorded for others
Okay.
that couldn't make it, but the overall thing I really like about your work, Paul, too, is Angela and other brought this out in some examples, is you have the issue of disseminating the results, which is important, and having a plan to disseminate, but also you try to advocate and do something about your results too. So that's a whole nother talk, I know, but it's really great. We really appreciate hearing from you directly about it, and how you've disseminated the results too, and put perspective on it. Deborah, many others are putting in the chat that they really appreciated the talk, but they do have to jump off. So thank you so much for joining us and having the seminar. And we really appreciate hearing about your work.
Oh, well, thank you. It's very kind. And I had a wonderful time interacting with each and every one of you. And